Hi, I'm Tarek Hassan, President of the Retina World Congress, and I want to welcome you to another edition of RWCE Live. Today, we're going to do a special event and starting of a series of CME accredited conferences where you will hear from the top key opinion leaders around the world talking about complicated topics that really play into our daily routines and management of some of the most common conditions we take care of. Today, session one of our CME series, we're going to be discussing the impact of recent clinical trials on the management of neovascular AMD. We're very happy to have an amazing faculty today, all wonderful friends and just amazing clinicians and researchers as part of our faculty. Jeff Heyer, Rishi Singh, Nancy Holkamp, Lee Tae Woo, and I'm joined on the panel by Barry Cooperman, Sundaram Natarajan, and George Rocha. So we're very, very excited to have you all with us. We look to have really the highest quality talks that you can imagine. All of our speakers have disclosures that they have put up here on this slide, and you will find also on the broadcast of this webinar, which you'll find on our website. We have continuing medical education credits this year in this series offered by AKH, and they are an accredited body that are very kind to have worked with us to acquire these continuing education credits, and the activity is indeed supported by an independent medical education grant from Alcon, Novartis, Regeneron, and REGENXBIO. And all of those slides that we have to go through get us to the learning objectives, and we really want to describe how clinical trial results differentiate treatments for our neovascular AMD patients based on functional, anatomic, and visual outcomes. And we're going to talk about ways in which even new therapies coming down the road are going to help us take care of our patients in this area better. At the end of the program, you'll be able to receive your continuing education credit. And at the end of this, you'll receive an email for those that have registered from the Retina World Congress with instructions on how to obtain your credits. So with that, I'm going to turn the program over to George Rocha, our Director of Communications at the Retina World Congress, who does so much tremendous work in putting on these great webinars for those of you across the world. And I welcome you all. I thank you, faculty, for being with us. I'm very proud to have you as part of our series of events. George, take it away.
Hello, everyone. Thank you, Tarek, for this very nice introduction. And today we're going to start a new series of CME credits. It's going to be wonderful. We're going to be 6 sections that go over all the year, and we're going to see so many things we face in your office with our patients. That is the goal. It's have the best vision and to have the best of we can do with science and trials. And then for the beginning, with this beautiful team we have now, we have our friend Rishi Singh from Cool University. Thank you, Rishi, to join us today, and I'm sure that your talk is going to be superb. Thank you very much.
So thank you, George. I hope you can see my slides.
We can.
Wonderful. Good. And it's a pleasure to speak to you all on a Sunday. I hope you all are well and safe in this time of COVID. And I'm going to speak today on some of the biomarkers for neovascular age-related macular degeneration. So I'm going to discuss some of the baseline features which predict final visual outcome, and I'll talk about the role of OCT parameters and findings during treatment as they are indicators for treatment outcomes. So when we think about baseline factors for poor response to anti-VEGF therapy, numerous studies have found the following are baseline features which indicate a poor anti-VEGF response. Greater foveal thickness, the presence of macular atrophy on the initial presentation, the absence of RAP, a larger CNV size, older age, are all poor predictors for visual outcome. But probably the largest predictor of visual outcome at baseline actually is baseline visual acuity. And this is some data actually from Marina and Anchor, which shows you the entry-level visual acuity and the visual acuity gains over the course of the study. And you can see there's some really direct swimming lanes that occur as a result of your initial acuity. So you are able to gain vision regardless of your initial visual acuity, albeit you don't necessarily get to the level if you came in earlier in that disease state with good vision. And in fact, one of the big helps to determine maybe prognostication of treatment outcomes as well as detection of disease has been around the increasing modalities we have for treatment. We have new modalities such as OCTA, and we're learning more and more about ICG and fundus autofluorescence imaging that can help us indicate disease activity and assessment. And here's where these modalities really shine. For example, fundus autofluorescence is very helpful at locating macular atrophy in the presence of neovascular complexes, as well as making sure you are not treating masquerade syndromes like CSR. And we'll talk about some of these other modalities in just a moment and how they've been helpful. Probably the one thing that we've been able to surmise from most recently, swept source OCT in particular, has been the advent of the fact that we can see neovascular complexes on OCTA without any presence of exudation. And this is particularly important when you consider some clinical trials, especially in the realm of geographic atrophy, that are looking at this, or intermediate AMD, for example, where you must make sure there's no sign of a neovascular complex because that might change your study results. And this is data from Phil Rosenfeld's group that shows this neovascular complex seen in the far right here in a patient without any sign of exudation on either the fluorescein or the ICG and on the OCT. So this is becoming an ever more important area of analysis, and certainly also one of the other things that is important to find as a biomarker for prognostication and potentially for treatment is this inverted U-shaped polyp formation, where you see these polyps above the RPE. You can have multiple polyps, or you can have one large polyp with cystic formation in and around it. And this is indicative of PCV. And I think that there's a lot of controversy. Maybe the panelists want to discuss the results from some of the trials, such as Planet and some of the Visudyne studies as well, to tell us what therapy they would use in this sort of treatment realm. But nonetheless, we think that the prognostication of this is important because there may be an indication to use maybe photodynamic therapy alongside our anti-VEGF therapy for this indication. Now, we are going to talk about the differential roles of fluid in each compartment with Nancy's presentation, so I won't steal her thunder from that presentation because she does a very good job with that. But I can just tell you that there's enough data now to suggest that IRF has a negative prognostication for final visual outcome. SRF, or subretinal fluid, appears to have a positive was a paper I presented at the Macula Society this year where I looked at Hawk and Harrier again, and I looked at the values that were below 280, below 320, and below 360 as cutoffs for a controlled state versus an uncontrolled state in this study. And we looked at this with regards to each of the drugs to see what the effect was. And you can see here that brolucizumab in this case actually led to more patients within a controlled CST state in comparison to the non-controlled state in all of the definitions we used. And in fact, the ability to convert to brolucizumab was higher to a controlled state than it was for aflibercept in this study. Now, what does that mean? Because that's just numbers, right? It actually leads to visual acuity changes. And here what you can see is broken out by each of those controlled states, the final outcome with regards to a non-controlled versus a controlled state and their final visual acuity. So clearly, if your CST was less than 320, your visual acuity gains were not as significant if your CST was, greater than 320. It was not as significant as you were less than 320. And again, look at 360, you see those deviations are even more significant at that. So this is, again, another way we can use a biomarker to look and see how we're doing with the treatment of neovascular AMD. Again, below 320 was a positive prognosticator for good visual outcome within this analysis. And this is just an example of what I do in clinic each and every day. This is our PAC system by Zeiss Forum. And actually, you can see on the graph, I'm able to automatically get all my CSTs, and my little injections there are all the injections. In this case, the blues are the aflibercept injections. And what you can see is I'm essentially keeping this patient at a very good central subfield thickness controlled state below 250 in this patient the entire course of their treatment. Now, what about the signs or biomarkers of early fluid on the OCT? And here is an analysis I also performed from Hawk and Harrier, which I presented last year at the Retina Society, where we looked at intervals of dryness during that initiation of treatment. And we look at this because a lot of us switch therapies within 2 or 3 or 4 injections because of fluid there, and people understand what the ramifications or benefits are of that. And here you can see what we did in this study was we said if you had any fluid in the first 12 weeks, we considered you an early residual fluid cohort patient. And what you can see essentially is if you had early residual fluid, it led to, in those first 12 weeks, less acuity, about 2.5 letters difference, than if you had a totally dry retina after the loading period. And in fact, when you compared the two drugs, you found that in the brolucizumab arm, you saw about a 6.5 letter gain in vision versus only about 3.5 letters in the aflibercept arm. Again, aflibercept was given not frequently enough, but nonetheless had a prognostication with final visual acuity if you had that early residual fluid. Now, lastly, one of the other biomarkers we see a lot on OCT is this finding you can see on this frame right here, and this can be confused for cystic change, but clearly there's a lumen here you can see, and this is actually autoretinal tubulation. And Bailey Freund and members of that group in New York have done so much as our understanding of this is improved. And really this is the loss of the outer segment form, essentially these tubules over time. And these tubules then can lead to a lot of interconnected areas. You can see here above a neovascular complex, multiple areas of that luminal change, outer retinal tubulation. And again, this does not indicate necessarily activity, but it certainly has a correlation with macular atrophy. And in the next slide here, you can see actually an en face image, which shows you how these can form really large complexes in certain patients. Again, en face imaging is the way to really find and look at the network of these over time. And here's just an example of a patient I had in clinic, that one I just showed you a moment ago, who's had this for since August of 2019, and really has had no injections since then the entire time. I've been sort of following this patient on a quarterly basis. And in fact, you can see I stopped giving this patient injections back in February 2019. I have not given any additional injections, but maintained stable acuity the entire time, albeit this patient has lost vision due to macular atrophy. And that's what ORT has been found to be associated with, essentially macular atrophy and a negative biomarker in neovascularization. This is actually from the CAT trial. This is an analysis of 437 patients within the study. ORT was present in 17.1% of patients at the 104-week time point. And this was a dynamic finding, that eyes actually can have ORT and then resolve ORT over time. And those have negative prognostication with visual outcomes because they're due to macular atrophy formation. And this was just a last slide I have in my deck today just to show you their comparison between aflibercept and ranibizumab with ORT formation. There's really no difference. And the prevalence of ORT increased independently of the drug chosen. So just to summarize, obviously this is a short talk and I'm not able to cover all the biomarkers for neovascular AMD, but some of the more prominent ones is the one I presented here. And again, I think we're learning more from the artificial intelligence programs and software that's being developed about how we can potentially use some of those analyses in our real world state. Those are really not ready for prime time. I've showed you some really great ways of doing it tomorrow in clinic, including CST variability and early fluid analyses. Maybe those are easier biomarkers for you to use to determine your clinical success for these patients. So thank you very much for your attention, and I'll turn it back over to George.
Thank you very much. I learned a lot. I have some questions, but I'll save for the end. I'd like to start with Barry. That's our coordinator of discussion. Barry, are you here?
I am. Thanks, George. Rishi, very nice talk. So how are you applying this? When you're doing your analysis of after the loading doses at 12 weeks, and you're looking at thickness, are you taking into account both IRF and SRF, or is it more of an IRF analysis? You subtract out the residual SRF? How, given the less predictive or negative predictive value of the subretinal fluid, how do you account for that in this analysis?
Yeah, it's great, Barry. Actually, I take into account both amounts of fluid. I'm not separating it. I think the bigger problem, though, and I think the real advantage of SWAP source OCT is the segmentation algorithms are better. And one of the things that I find a lot, if you use these values, is you really have to be careful about the segmentation. Areas of a PED or neovascular complex, for example, they'll get segmented all different ways on an SD-OCT right now. And you just have to be really careful about making sure that those boundary lines are drawn appropriately.
And we all notice that even on the regular OCTs, you have to look very carefully where the reference lines are. They're frequently well out of alignment.
Rishi,
but you use this as a regular paradigm for making decisions, or are you still evolving this?
I think I use it more often than not. I think the idea of finding fluid on an OCT, it's either positive or negative. There's no quantification right now. And all the studies thus far, and I don't want to steal Nancy's thunder, but all the studies have treated fluid regardless, and this is just something that is associated with it, right? So it comes out, and it comes out, as a biomarker at the end. It's not like we're ignoring it or not treating to it. And so I just use this quantitative way more often than not in clinic to make really real-time clinical decisions, because it appears to be a scientifically sound way of approaching these patients.
Rishi, very interesting, great talk, and it'll be interesting to talk again after Nancy's presentation, because it does deal with that. But when you get to the variability question, which is really so interesting, and variability doesn't necessarily say that you are dry, it just shows variability, and I think that maybe will be a point that will be brought out later. But you think that we as clinicians then have the control to prevent that rather than react to the variability, basically prevent it? So I think 90+% of us treat with a treat and extend model. What if we didn't do that? Wouldn't we reduce variability? What if we had shorter intervals? What if we did treat and extend but extended much slower than we do? I mean, at what point do you feel that we can use this information, this concept of variability, as a way of minimizing? We use it preventatively to not have variability.
Yeah, it's a great question. I think it's a multifactorial sort of approach to this. And actually, one of the reviewers of our paper pointed this out. When you look at variability, you could have a very, very thick retina and have a very low variability because you're not affecting treatment outcome, right? You're giving injections month after month, and your variability is very low, but your retinal thickness is like 450 microns. Well, that's not a good outcome necessarily. You can't look at, I think, any of these in isolation of each other. And I think your point is well taken, Tarek. Treat and extend was a way of obviously attacking the fluid concept, but potentially reducing the variability concept. That's all of us. We wanted to do that because we realized the yin and the yang of the retina over time probably wasn't the most positive thing for photoreceptors and visual function. So we've adapted to treat and extend to reduce variability, albeit I think it's as we're pointing out here, is not in isolation, can't be considered the only biomarker we need to look at.
So
one thing, oh, go ahead, Nancy.
Oh, I was just going to say, when we look at trampoline effect, and Tarek, you brought this up, we don't really know if those eyes are getting dry. So in between their OCTs, in between their visits, you know, do the really, really thick retinas never get back down to zero? Fluid? Do the thin retinas get back to zero? And maybe that's the difference in visual acuity. So we really need to take a look at what's happening when we're not seeing the patient, and see who's getting dry at the in between visits and who's not.
So Nancy, to that point, it's perfect you brought that up, because Nancy and I are involved in a home OCT study, and we're actually looking at daily OCTs on patients. And so that exact question will be really interesting, and I think could help manage these patients. Risha, you mentioned the early residual fluid, and you showed the difference with Brolu and aflibercept. It's interesting because from the VIEW studies, actually we showed that aflibercept monthly was superior to aflibercept Q8. So I think that study really highlights that in some patients, you're going to have to dose much more frequently to maintain both that vision and the anatomic desired outcome.
Yeah, absolutely, Jeff. And I think that the data also shows you, and this is where it gets to obviously our US issues more, maybe it's international too, which is that we face incredible insurance pressure to use certain drugs at a given state. And the frequency of our ability to change sometimes is based upon how many injections we give. So we might have to give 2 or 3 injections before we see a negative response, and then ask an insurer to pay for a new drug. Clearly, that's a problem, because if you wait 3 injections, you can have a detriment in a line of vision potentially at a year's time. And you're absolutely correct. The data in VIEW 1 and VIEW 2 is replicative of what we saw here. And again, I'm not promoting the idea that Brolo is obviously better at doing this than aflibercept given every 4 weeks. I think it actually probably is very complementary. At least the Brolo in this case was given only every 8 weeks in the study. So I think it was an interesting outcome, yet any of these drugs are subsequently, unfortunately, regulated by what our payers are willing to give us the first couple injections.
Well, to follow up on that, Rishi and Jeff, you know, every time that in any study that we look at any regular injections, but on a slightly more extended basis, we always see that sawtoothing of the OCTs. That's a consistent finding. And yet we've not always seen within the limits of the clinical trial of 1 or 2 years, 2 years being typical, significant disparities in vision. But the concern is that that is something that would be manifest in real life setting over a more prolonged period of time. So that is the concern. Many of these sort of the label then works against themselves. They're trying to promote themselves as a Q8, a Q12, Q16 drug coming up. But the reality is that many of the patients will suffer from that regimen because they'll have intermittent fluid, and as Nancy pointed out, periods of time of fluid in between each injection.
And Barry, those clinical trials, you know, we lose individual data in the means. And so we really don't know what's happening to the individual patient we might see in our clinic.
And that's even further accentuated by the fact that we all, just as a community, went away from fixed interval dosing, me included.
Right.
But I mean, we have webinars based on all of this stuff that in some way, these questions exist to a greater degree because we don't do fixed interval dosing. That was more done in the earlier trials that showed the benefits that we use for labeling, and that's how we've gotten these things approved.
Rishi, you mentioned that the AI platform has got a promising data, but cannot be used in the current state. So what's the problem of it?
Well, I think Nancy will touch on it, but my impression, Nutty, right now is there currently is nothing embedded within our OCT platforms. Now, I know that we've worked on some validation work with Zeiss, that will come out probably by the end of this year, that there will be some amount of fluid presence or absence, especially for our people that aren't familiar with OCT, maybe our optometry colleagues or general ophthalmologists who can't read an OCT. I mean, obviously, if retina specialists, we know if there's fluid or not, but it'll be those sort of things. But the quantification is, I think, the most important thing we could possibly do. And those only exist right now in some of the research protocols and people like the Vienna Reading Center who do this sort of work, and Basada's work out in California. those are the places where it's being done, and that's probably going to be very helpful. The quantification values show you, I think, some really different results than the true presence or absence, and I think Nancy will cover that in her talk too.
Nancy mentioned that individual patients' data we don't know in a trial when you have the results. So what do you do for that? How do you learn from the individual patients?
It's hard, I think it's such a, unfortunately right now, I think neovascular AMD, if I had to summarize, is just a heterogeneous approach for every patient. I would wish there was a biomarker I could show you that says this is a 12-weeker, this is a 6-weeker, this is somebody who needs less treatment. The answer is we just don't know.
And
Well, that problem is even more compounded in our diabetic patients. We have suffered from an even greater degree of variability and therapeutic dilemmas.
Ishi, going for the membrane that's not non-clinic, that has no fluid, and that's we know that's have more probability to turn to be clinical stuff. How you follow your patient when you realize that they have a non-clinical membrane with no fluid?
Oh, yeah, that's great. The answer is there have been some patients I found that in. I've shortened the interval. Actually, in my intermediate AMD patients, I'm actually getting OCTAs on all of them now, and looking to see if there's any flow in that drusenoid sort of area, which is confusing looking at best. That's the one where I've been able to, at least even with SD-OCT, find those membranes and actually image them nicely. And then I'm cutting their intervals. I'm seeing them every 3 months instead of every 6 months for intermediate AMD, and following them closer, talking to them about the exudative symptoms. And actually, through the pandemic, there's been a plethora of online apps that have come out that are like quantitative Amsler grids and things like that are available. My Vision Tracker is now available. A few other ones are available that are pretty good. I would advocate your patients download these and try them and try to measure themselves quantitatively to see if there's a change. That's the only option we really have to do right now until Jeff and Nancy's study comes out with the home OCT. That would be very, very helpful for these patients, clearly.
Yeah, I think in the near future, you're going to have a very good tools to follow these patients with home OCT that's really going to show us a real-world variability of the fluid and all the new stuff that patients can be checked at home. I think it's going to be real turning point for our treatment, because we're going to check the patients every day. But anyway, it's very nice, but have to move on. And now we have the Lite. But thank you very much for all the discussion, the great talk, Ishi. I love your talk. And now we have our friend from Costa Rica that's very well known, Lite. How, Lite? Go ahead.
Good morning. Thanks, George Tarek, for the opportunity to speak today. I will be talking on the long-term treatment outcomes. These are my disclosures. And it's been over a decade and a half since anti-VEGFs were introduced into clinical practice. And what have we learned in those 15 years? So we've learned that anti-VEGF are the treatment of choice for exudative neovascular AMD. Exudative neovascular AMD is a chronic disease. Indefinite injections need to be given in a large percentage of patients. The visual outcomes correlate with the number of injections, and the patients in the real world or routine clinical practice are undertreated, and the visual outcomes in the real world lag the outcomes seen in randomized clinical trials. You're all familiar with these type of graphs that were that were presented in studies like the Marina, where you see an improvement of vision over fixed dosing over 2 years. But the question is, are these results sustained? And we have some idea when we look at the Horizon and the 7UP study, and you can notice that slowly with time, the vision gains are lost. However, if you look at when you look at the number of injections, you can see that in those eyes that had more injections, more vision was preserved. And this is a publication by Nancy and colleagues where they actually look at this, and there's a strong correlation in randomized clinical trials where the number of injections correlate with the gains in visual acuity. Again, in Nancy's paper here, they were one of the first who looked at the real-world use of bevacizumab or ranibizumab, and you can see clearly here that the range of number of injections wasn't really high as compared to the recommendations in the label in those early years. So they concluded that patients received less injections in routine clinical practice in the States. A larger study here and more recent, you can see here in the period of 2009 to 2016, that if you looked at the number of injections here, and it seems they use 7 injections, you could see a difference in the gains of the patients with the number of injections. So in eyes that had more than 7 injections in that first year, you had more gains than those that had less than 7 injections. And in each additional injection, produce a gain of 0.37 letters. So people start looking at why the results of the real world do not really emulate the results seen in randomized clinical trials. And one of the first studies that looked at this was the AURA study, and they concluded that perhaps one of the reasons was the number of injections and a failure to visit clinicians and OCT monitoring because of the burden of treatment. Recently, this study from the IRIS registry showed us that in over 160,000 eyes, about a third of eyes presented with a visual acuity greater than 20/40. And in those eyes that had a presentation of greater than 20/40 visual acuity, they maintain a visual acuity for 2 years after treatment initiation. So the early diagnosis of neovascular AMD is critical in preserving visual acuity in neovascular AMD. Just like you saw, that was the main baseline biomarker that Rishi pointed out in his previous talk. This was also seen in Japan in a smaller study, almost 300 eyes. And after their loading dose, they noticed that the baseline better best corrected visual acuity and a smaller lesion predicted a better visual acuity at 5 years. So let's look at what we have seen over long term. And this is a study from the UK, which was a revision of 26 studies from the UK. And they mentioned that over the last decade, with the adoption of treat and extend or fixed doses versus PRN treatment, the outcomes have improved. However, the results still lag randomized clinical trials. Obviously, not too many patients have been reported with more than 10 years of follow-up. So this is a small study from the UK. And you can see here that over 10 years, the visual acuity declined by a little bit more than 2 lines, more than 15 letters. And you can see that the mean number of injections was 47 in those 10 years. However, it's notable that almost 20% of eyes still had 20/40 or better visual acuity. In Denmark, close to 5,000 patients were treated with a PRN regimen of either ranibizumab or aflibercept, and these were patients that were followed for 10 years. And then, initially in the first year, they had 5.4 injections, and then between 4 and 4.3 thereafter. You can see that the baseline visual acuity was around 20/60, and they had a little gain after the loading dose and then slowly declined to -5 letters at 10 years. Again, it's notable that about a third of patients have maintained a visual acuity of 20/40 or better. So they concluded that the PRN treatment with either anti-VEGF stabilized the visual acuity in most eyes with neovascular AMD. It's important to see this study where we have data from New Zealand, Australia, and Switzerland, and they looked at the patients where they had the mean remaining lifetime after initiating anti-VEGF 11 years prior to treatment. And of those patients, 12% retained drive-in visual acuity, 15% reading visual acuity in at least one eye. However, 82% of the patients had dropped out by this time. And the predictors of those that did better were younger age at baseline and more injections during the first year of treatment that were associated with better long-term outcomes. And perhaps, the reason for that is if you have more injections, maybe you had a better vision, and that was an incentive for the patients to continue treatment. Whereas if you did not have such a good outcome, then patients would probably get disappointed and not continue with the treatment. Let's look into more detailed experience of Australia and New Zealand compared to Switzerland. And these were patients that started with anti-VEGF treatment in 2006 and 2008. You can see that about a third of patients from down under completed 10 years of follow-up versus only around 10% of patients from Switzerland. And you can see here the differences between their approaches. You can see that the outcomes from down under were much better than those from Switzerland, and it had to do attributed to the number of injections. They had many more injections in Australia and New Zealand compared to Switzerland. This is another study where from Australia as well, where they looked at over 1,000 patients that started with anti-VEGF between 2006 and 2009. And you can see here that over 10 years, most patients maintained some type of visual acuity, although, this was slowly lost over time. But importantly, about a third of patients maintained 20/40 or better. So they concluded that if you continue with regular treatment, the eyes were able to maintain baseline. But it's not just the number of injections that is important, because as the study showed, they looked at two different cohorts where the number of injections was similar. However, there was a difference in the mean gain of visual acuity. Here you can see the differences in the mean gain in visual acuity, the differences in patients obtaining 20/40 or better, and even in the reduction on OCT. And the differences were mainly due whether or not the patients were treated on a timely basis versus not being treated on a timely basis. So timely retreatment of active disease is important to ensure optimal outcomes. So this is a survival analysis of almost 8,000 patients that were treated with ranibizumab or aflibercept. You can see that about 2/3 of patients achieve 20/40 or better, and this was over 12 years of treatment. And here they show that the median time to attain 20/40 was 2 years after the first injection. So it's not so this shows a more gradual improvement in vision. And once the 20/40 is attained, 50% were able to maintain it for a little bit over a year, and 25% were able to maintain it beyond 3 years. So it would be interesting to discuss this in the panel. What are the reasons for not being able to maintain the visual acuity, even if we're treating accordingly with the anti-VEGF? Maybe some macular atrophy is creeping in, the natural history of the disease. We'll discuss this with the panelists. And finally, why are patients in the real world not really treating the patients accordingly? And these couple of studies have looked at the reasons why. So there are physician factors. So every one of us are involved with this. We are seeing ever-growing clinic volumes. And quoting Jordi Monés and colleagues, they say that there's a general mindset in the ophthalmological community that sustained benefits with treatment are not possible. So our role as speakers in this disease is to try to change this mindset in our colleagues that treating is worthwhile for these patients. And in addition, there are patient factors, and these have been strongly correlated, such as the increased systemic comorbidities, which makes the patients need to see other physicians, longer distance from home to treatment center, the difficulty of going from home to different places, the lack of a caretaker to assist with transport, and poor baseline visual acuity, as we mentioned, are reasons why, and also the treatment efficacy. And here I'm going to introduce a couple of concepts that have been talked to, which is the adherence to treatment, which is the extent to which a person's behavior corresponds with the agreed recommendation from a health care provider, and the non-persistence, which is the ability to continue with the therapy. And this is a review where they looked at the non-adherence or non-persistence to the treatment for exudative macular degeneration. And they say that non-persistent occurred rather early, with half of patients stopping treatment within 24 months. And so the barriers to treatment include that there is a treatment burden is the most significant barrier, because the visit frequency and the travel time. So in summary, exudative neovascular AMD is a chronic disease. Anti-VEGF treatment is the treatment of choice, and the vision outcome depends on the injection frequency. The best outcomes are obtained with regular monitoring and frequent injections, and early detection is important. Thank you very much for your attention.
Lite, great talk. It's something that's everyone are pursuing, is to have vision for a long time for our patient. If you think we have now almost more than 15 years that we're using anti-VEGF for macular degeneration, since 2005 in Toronto, when Philip Rosenfeld showed us the first case of injection of bevacizumab. And then we have, we point out some biomarker like the early diagnosis, the number of injections, and maybe the type of the membrane that we are not discussing yet. But we need to keep this. But something that's I always talk with my patient is, when you have macular degeneration, we have a lifetime treatment. We never stop. We have to see each other until the last day. And then I think is the real thing. And one thing that's happened, my patient, that's they keep very, very adapt to the therapy, is when they have the disease in one eye, and this eye was not good because they not follow the instruction to come up and do injections. When they got the disease, the next eye, they really are very comprehensive for the treatment. They have much better results in the follow eye. But you know, Barry, I think start with you. That's
a great talk. You really covered a lot of the issues that we have to face in the real world with managing our patients. What are you doing to adjust to this? I mean, I have like several thoughts. The emerging therapies are going to be interesting. Again, the port delivery system will be a different type of therapy. Faricimab with a, different, the bispecifics and the different intervals may, the hope is that those will give us a new era of better and long-term results. But what are you doing to manage to achieve your better results? How aggressive are you? What's the protocol you tend to use that you favor that works best for you and your patients?
So Barry, I think the first thing is to educate the patient. The patient needs to know that we don't really cure macular degeneration. So I usually use an analogy as telling the patient that this is something similar as if I had just diagnosed you with hypertension. So if you're hypertensive, I give you the pills. And if you take the pills, your blood pressure is going to be under control. You stop taking the pills, the pressure is going to go up again. So that is one way to explain to the patients, because unfortunately here in Latin America, there's still a lot of lack of knowledge. And I see lots of second opinions where patients come and the patient said, well, so-and-so told me that after 3 injections, that's it, So I said, I have patients that I've injected 150 times already, and we're still doing it. And so one thing is, once you educate the patient, then I tell them about the different protocols, and I favor doing treat and extend for these patients.
And do you have a limit as to how? Go ahead, Nancy.
Oh, I was just going to say, Lite, first of all, great talk, because it's a global problem. I loved how you gathered data from all over the world. When we first started talking about under treatment, everyone would hear the data and say, well, that's not me, that's some other guy. And actually, we all have this problem. It's a global phenomenon, and what you're experiencing in Latin America still happens in my clinic. So I'm doing a follow-up study that I've submitted as an abstract to ARVO. It'll be a poster, but we're looking into the reasons why patients don't come back. And so we interviewed, we had professionally trained interviewers ask patients, caregivers, and their doctors, what are the barriers and what are the motivators? And the motivator was education. Patients, caregivers identified education, understanding their disease. And the second was the patient-physician relationship. And then the third was feeling some type of benefit from the treatment. And I think this gets back to what Jorge was saying, that, if you see that you're getting better, you tend to come back. Or if you have one eye that's down the tubes, you might come back. So it's interesting to look at the motivators, and I think it's important to get patients, their caregivers, the person driving the doctor, to understand what's motivating people to come back. But education was number one. You're absolutely right.
So it's really interesting that you mentioned that, Nancy, because here during COVID, all my one-eye AMD patients, they were always in the clinic. They said, I don't care, I don't care about COVID or anything like that. I care about my eyesight.
Yeah, you're right.
Mm-hmm.
You push the interval. Oh, go ahead, Jeff.
Lite, great talk. And as Nancy said, I think bringing in the whole world data is really critical. The real world data is overwhelmingly clear that the more you treat overall, the better the outcomes. And the AURA study showed that it was directly related to each country that had the most treatments and those that had the less. It just followed exactly. So it's pretty clear, even when I've had the opportunity to go to the FDA and discuss clinical trials, and we talk about treatments that will decrease the number of injections, the FDA often says, I don't understand why you and other clinicians are so interested in decreasing injections, because all the data is pretty clear. The more you treat, the better the outcomes. And it's why just eliminating injections or reducing treatment frequency is not an acceptable endpoint to the FDA.
Yeah, they're very disinterested in that. That's very true, Jeff. But Lita, so do you push your treat and extend interval based on this? That was sort of what I was getting to. You aim for Q12. Are we better off not going as far as Q12 with our current strategies? Should they be more, keep them at Q8, Q10 to give them more injections? Is that better for our patients, or is that overkill? That's sort of what's in the back of my mind as I listen to your talk.
So I think it really depends on a patient-by-patient basis, because like Rishi mentioned in his talk, we have this wide spectrum of disease in all these patients. So it's definitely overkill in some patients, because I've been treating some patients with Avastin over 10 years with every 4 months. On the other hand, I have other patients that I need to treat on a monthly basis with Eylea. So, it just depends on the degree of activity of that individual patient.
Agreed. Sorry,
Yeah.
George, you were going to say something.
So, Peter, we just talked that if you have more injections, we probably have a long-term better vision. But how will think about the concept of having more injections and we stimulate the geographic atrophy? What are your impressions about that?
So I think the jury's still out on that. I think it's a controversial topic. My personal feeling is that 20% of patients with AMD will go down the neovascular route for some odd reason, and once we control that, we're putting them back on the regular AMD track and the natural history progression of disease. I'm not too convinced that treating aggressively with anti-VEGF is the cause of the macular atrophy. And as a matter of fact, I think that we're doing more harm by withholding injections in the hopes of trying to avoid atrophy.
We'll certainly get our best sense of that, George, when we get a full look at long-term PDS, the port delivery system data, where there's chronic delivery of anti-VEGF. That'll certainly unmask whether, and I think what Lee test says, whether that's true or not. We'll be able to get a better handle on that.
And some objective data from the CATS trial actually showed that those patients in the PRN arm actually had greater macular atrophy than those in the monthly arm, which contraindicates and supports Lite's opinion, which is that it really probably isn't more frequency as it is the yo-yoing effect and other things that might be affecting these patients over time.
Yeah, I agree completely with you, because in my impression, some patient that has geographic atrophy, it's not because I have more injects or not. It's just because the disease is different, has another factors that we don't measure. And we think that when we inject more anti-VEGF, we prevent fibrosis, if that's something that's destroy vision.
Well, the problem is we really don't know, right? If we want to actually be critically looking at ourselves, we really don't know. So we only have one endpoint to treat towards, and that is the management of the fluid. So I think that for us to postulate beyond that without really convincing data is not fair to the patients if it affects how we treat them.
And I think in India, generally, Rishi knows that when he wanted more patients of GA, and we don't see much in India, but I don't know whether anything is related to maximum number of injections and geographical atrophy, but we don't see overall geographical atrophy. And I also agree with Nancy that education is important. I am trying to tell my patients, whether it's diabetic or AMD, that in spite of the COVID, please make all precautions and come to the hospital and we'll do it. But sometimes people think you're trying to get more patients, but the problem is I'm trying to make a study that because the patients don't come for follow-up, they're losing vision. And then somehow, because one eye they're losing and the other eye, it's all right, they don't come. So it's a real sad state. And as Lite mentioned, a great talk, Lite, you collected, maybe we should have some data from India too. But I think the one-eyed patient probably is more concerned than the patient with one eye with good vision and another eye having an AMD with less vision. So it's a great difference.
And I suspect in India you're going to see more of this as you go along, Nadi. I think the population has changed, right? So Western diets have been initiated in India. People are the longevity, especially in Indian males, was not very long, and so I suspect that as they live longer with more dietary things, we're going to start to see that. But you're absolutely correct. It has been so tell me, 20 years ago, was AMD prevalent at all in the population as it is today? Is the same prevalent?
Yes.
You think so? It hasn't changed since then? Yeah.
But it's definitely longevity is increasing. And I think probably what the mind does not know, eyes do not see. And I think the earlier probably they were missing. Same thing happened to IPCV, which we were considering everybody as AMD and leaving it. So I think now, since we have many of OCT, angio, and some people still do FFA and ICG, and I think I make it a point I tell the patient, if you're willing, we like to do all the study to make sure we live long and also have a good patient.
Appreciate comment to what you just said. I remember talking with Europeans 15 years ago, and they would comment on when we'd show pictures of our patients, and they would see these big fluffy drusen, and they say, we don't see that at all. And now they do. So we've exported our horrible diet to the world. So the diabetes epidemic is thanks to McDonald's and the rest of us Americans, but also the characteristics of the drusenoid formations may be, again, associated with not just the Western diet, but the American diet, which we proudly have one of the worst diets, meaning it's super caloric, but it's super fat.
I think smoking obviously is larger in Southeast Asia now, and we're seeing more of that, and obviously exports of things like the kernel have really caused of that worldwide, unfortunately, issue with Western diets.
Anyway, it's the discussion so hot that we can't stop, but the time is flying. And thank you very much, Lita, for the wonderful talk. And now I'd like to have Nancy. It's a fantastic speaker, and we're gonna have the very nice time with her talk. Nancy, please.
Thank you very much, George. So over the next 10 to 12 minutes, we're going to discuss fluid in AMD, friend or foe. And of course, it's not a black or white answer, and we're going to try and tease that out. Those were my financial disclosures. And there's three questions we're going to address. And the first is that generally, we all have been trained to treat to dry. And despite our best efforts, how often does fluid remain? And I think you're going to be surprised by the answer. In wet AMD, we differentiate between intraretinal fluid and subretinal fluid, and how does each fluid compartment influence the visual acuity outcomes? And then finally, how much persistent fluid can be tolerated for best visual acuity results? And Rishi touched on that a bit, and we're going to show another analysis that corroborates what he presented earlier. And we're going to use clinical trial data to try to answer all of these three key questions today. And the first trial we're going to look at is a Harbor post hoc analysis that I originally presented at the ASRS meeting in 2019, and this is how I kind of got interested in this fluid question. And here we just pulled all the ranibizumab arms, so we had 917 patients. We had 24 months of SD-OCT images, and the first take-home message was that most of the eyes, 86%, had subretinal fluid at baseline. And about 63% of the eyes had intraretinal fluid at baseline. So that means, some eyes had both types of fluid. But after treating, at 12 months and 24 months, 18 to 20% of eyes still had subretinal fluid. And if we look at intraretinal fluid, 27 to 28% of eyes still had intraretinal fluid. And this is not with undertreatment. It's not due to the undertreatment we see in the real world. These patients were treated in a clinical trial, either monthly or PRN, with very rigorous retreatment criteria. And then you might ask the question, how much fluid did they have? Well, when we look at subretinal fluid, it was substantial. There was 90.6 microns, 82.6 microns of residual subretinal fluid. So, despite our best efforts to treat to dry, a lot of patients aren't getting dry. So how does this impact visual acuity outcomes? And again, we're just looking at post hoc analyses. And there's a pretty early analysis of the VIEW clinical trial that shows, if you look at week 24, so that's 6 months, eyes that were diagnosed as being persistently dry through the first 6 months, and then you compare them to patients who either had persistent fluid or recurrent fluid, the visual acuity outcome really wasn't any difference. And on the right-hand side of this slide, what you're seeing is that whether the fluid was foveal fluid or non-foveal fluid, it really, after baseline, it really didn't seem to affect visual acuity, that within the error bars, the visual acuity results were the same. Here's a more recent analysis, again, from the Hawk and Harrier clinical trials, and it shows on the vertical axis the patients with persistent intraretinal and or subretinal fluid. So we're looking at total fluid here. And I want to draw your attention to week 48, both in Hawk and Harrier. And we see that number of eyes to be 45% with the aflibercept treated arms in Hawk and 44% of the treated eyes in Harrier. And that's really surprising. These are SDOCT OCT results. They're being read by a reading center, and that's a fairly high percentage of eyes. Now, we also know in these aflibercept eyes that there's this sawtooth effect that came up earlier in the discussion, and we saw it in Hawk, and we see it in Harrier, and we know we're not really seeing it with brolucizumab because the drop-down means people are being treated at different intervals. But again, when we look at the means, and Barry mentioned this, when we look at the averages, it doesn't seem to affect visual acuity outcomes in these large randomized clinical trials. So just to kind of address that first key question is, despite our best efforts to treat to dry, how often does persistent fluid remain? And I just showed you data from the Hawk and Harrier clinical trial that for aflibercept at week 48, it was about 45% of eyes still had fluid. And we have to think about how we continually treat these patients over the long haul that might still have fluid despite our best efforts. But there's also this signal that when you look at mean visual acuity outcomes, again, all we have data on right now is the mean visual acuity outcomes, persistent and or fluctuating fluid doesn't seem deleterious in these large clinical trials. So that's the first question I was going to try to address today. The second key question is, in wet AMD, should we differentiate the fluid compartments and how does it affect outcomes? And, we all know that intraretinal fluid are those cystic spaces within the very fabric of the retina, and subretinal fluid lies between the photoreceptor outer segments and the RPE. And the question is, when we look at these independently, does it affect visual acuity? And I'm going to go back to that present topic now almost 2 years ago at the ASR's meeting in 2019. And here, the turquoise bars are the eyes that at month 12 or month 24 had persistent residual subretinal fluid. And the white bars are the eyes that resolved their subretinal fluid with treatment. And what we see is that subretinal fluid was associated with better visual acuity outcomes, and the difference was statistically significant. So it's not just that they had the same or that they were both good, but persistent subretinal fluid had better visual acuity outcomes when we looked at mean change from baseline. And this was really provocative for us looking at this data. And then we looked at the propensity to have 20/40 vision or better, and it was exactly the same, whether you had subretinal fluid or resolved subretinal fluid, both at month 12 and 24. But in contrast, we then looked at intraretinal fluid, and here the orange bars are patients with persistent intraretinal fluid identified by the reading center at month 24, month 12 also, and the white bars are the resolved intraretinal fluid. And here, persistent intraretinal fluid was worse, statistically significantly worse. And when we looked at the propensity to be 20/40 or better, again, it was worse if you had persistent intraretinal fluid at both time points. So I really like this slide because it shows the 4 permutations of what you can have. You can have the blue bar, which would be persistent subretinal fluid only, and on the other end, that orange bar is persistent intraretinal fluid only. But in the middle, you could be completely dry, which is the white bars, or you could have persistent types of both fluid, which is the lavender. And we see that the eyes with persistent subretinal fluid do the best, and the eyes with persistent intraretinal fluid do the worst, at least in this Harbor post-hoc analysis, when we look at mean change from baseline with best corrected visual acuity. But here we're looking at actual letter scores, best corrected visual acuity letter scores on an ETDRSI chart. Look at month 24. The white bars, the eyes that still had persistent both types of fluid, was identical to the eyes that were dry. Again, at least in this post hoc analysis. Very provocative data. So, this is a post hoc analysis of a single study, hypothesis generating, sure, but what can other studies potentially tell us? So here's a view post hoc analysis again, looking at intraretinal fluid on the left, subretinal fluid on the right, through week 52. And when you have intraretinal fluid, there's a trend toward worse visual acuity at every single time point examined through the first year of treatment. And when you look at whether the fluid is non-foveal or foveal, but if it's subretinal fluid, there is a trend toward improved or better visual acuity outcomes at every time point through the first year. Now that's 1 year of data, but now we have the CAT trial looking at this very question through year 5. Again, the numbers get very small at year 5. They're no longer within the confines of a clinical trial, but again, we see intraretinal fluid portends a worse visual acuity outcome and subretinal fluid potentially better visual acuity outcomes through year 5. So again, we get this feeling that intraretinal fluid is damaging to vision. Subretinal fluid may be beneficial to vision. Post hoc analyses, should these influence our treatment decisions? Is there a prospective randomized clinical trial to help us that actually ask this very question? And we're fortunate that there is. And it's the fluid study from Australia. It was a really bold study design. I love this clinical trial. And basically they had 2 groups, treat and extend using ranibizumab, but the relaxed group tolerated up to 200 microns of subretinal fluid, and this intensive group treated all fluid to the death. They tried to get rid of all intraretinal fluid and all subretinal fluid. And again, in the relaxed group, they treated intraretinal fluid to the death, but tolerated subretinal fluid up to 200 microns. And what we found, if you look at both of these graphs, just 2 different ways to slice or dice the visual acuity outcomes, that the relaxed treat and extend group was non-inferior to the intensive treat and extend group at the 24-month time period. And it suggested that aggressively treating subretinal fluid does not affect vision gains, and therefore a zero-tolerance approach to subretinal fluid may not be required. Now, just a little footnote here that in the relaxed group, because they were treating intraretinal fluid to the death, they actually didn't have many eyes that had 200 microns of subretinal fluid. There was generally less subretinal fluid because I think 200 microns would make all of us pretty uncomfortable, but they weren't aggressively chasing or trying to get rid of subretinal fluid in this treat and extend protocol. So here's kind of a summary slide for that second key question. Take-home message, intraretinal fluid, we should treat it aggressively. Subretinal fluid, maybe we can tolerate some subretinal fluid. And I think it'd be interesting for the panel to discuss why subretinal fluid is protective. And getting back to that GA question, is subretinal fluid protective against GA? And I know that Bailey Freund is a strong advocate for that hypothesis. Okay, third key question, just to sum up, and Rishi again touched on this and showed some very nice analyses. I have a third analysis that's basically going to say the same thing. How much persistent fluid could be tolerated for best visual acuity outcomes? You know, we're talking about that trampoline effect, that excursion. And this is an analysis that I did with Jeremy Wolf, and Jeremy presented it at the virtual ASRS meeting in 2020. And we looked at Cedar and Sequoia phase 3 clinical trial data because that Q12-week arm of abicipar had a very nice excursion. And in fact, if we just isolate the OCT excursions of that Q12-week arm, we can identify 3 periods of time between dosing. The first dosing interval is at week 16 to 24. The second dosing interval goes from week 28 to 36. And the third interval from week 40 to week 48, and we're going to look at those excursions. And what we find is that if you greater than or equal to 75 microns, Well, it was associated with decreased BCVA gains. However, if it was something less than 75 microns, you still could have good visual acuity results. And I'm showing you that first period of time between week 16 and 24. But one of the strengths of this study is we looked at it again at week 28 to 36, and we got the same results. And certainly in that third interval, if your rebound was greater than 75 microns, you really didn't have robust visual acuity gains, or at least a chance at that. And I think Rishi's number was about 68 microns. I think that's very close to 75 microns, but probably a good rule of thumb. But this analysis, and I believe that's true also with Rishi's, is we looked at total fluid, and these analyses did not address fluid compartments. And these analyses really can't tell you who was dry, who reached dry, or if there was persistent fluid in between the visits. So a final point is that most of the patients are dry, that this was a small number of patients who had excursions that were greater than 75 microns. So again, just a summary slide for this third key question. And, 75 microns of total fluid is probably a good number to hang your hat on, that it negatively impacts visual acuity outcomes. So just a summary for the presentation here is these three key points, that there are still a lot of eyes that have persistent fluid, and we have to know how to deal with them. And should we separate out the fluid compartments? Yes, and I think future AI algorithms are fortunately going to do that, and maybe the panel would like to talk about the potential for AI to help us. Fluid can be tolerated, anything less than 75 microns of fluid. And with that, I'll say thank you, and I will turn things back to our moderators, and thanks for your attention.
Nancy, thank you very much. It was amazing. And I really thinking that in the old time, my concept in my mind, it's all fluid is bad. I tried to dry for any way. And now with new concept, I feel much more relaxed because we have fluid that's not bad. And the subretinal fluids, and maybe we shown so many good data that they protect vision. And my question is, do you know the rationale, theoretical, how they protect vision, how this subretinal fluid is protecting us to lose vision?
So I want to start with just one caveat. In the post-hoc analyses that I showed you, everyone was trying to treat to dry. So nobody was tolerating fluid in any of those studies until the fluid study came up in Australia. And now we are starting to see clinical trials like Altair and Aries that actually prospectively tolerated fluid. So it's kind of a new thing. It's interesting to see how this landscape evolves. But back to your question, how might subretinal fluid be protective? Well, if we look back at when macular atrophy was a really hot topic, and we did post-hoc analyses of the CAT trial and IVAN, it seemed that subretinal fluid was protective against macular atrophy. And here's the hypothesis, and I really want the whole board here, the whole committee to weigh in on this. But if you are thinking about macular degeneration as being part of the complement-mediated system, and you think about the MAC attack causing apoptosis, if you get cell death, I think you're getting atrophy. But if you're not really getting cell death and you're getting ischemia, then you're getting release of VEGF and you're getting some blood vessel growth. And that's what we're targeting with VEGF, and we're treating choroidal neovascularization. And there are people who think of wet macular degeneration as being a reparative process, like granulation tissue growing in these blood vessels to combat ischemia. So you're going to have either ischemia with, VEGF, generation as the preferred state over having atrophy and cell death. And I think Bailey-Freund shows some really beautiful cases where there's this front of neovascularization, and all around where the neovascularization is coming and going is this horseshoe ring of atrophy around it. But that's, it's just a theory. That's individual cases. It's hypothetical. I have no data to support what I just said, but I'd be interested on the views of others.
And that's your point's well taken, and that hypothesis is still being explored. We do also know, just to remind you, George, of course, the obvious is that you look at VEGF, the agent itself, besides being an endothelial growth factor, its next most important role outside of vascular role is it's a survival factor. So in some way that is playing into this. Why subretinal fluid is protective versus intraretinal fluid, how that interacts with the whole role of VEGF as a survival factor is unclear, but that's at least another part on that deck to discuss. The question I had for you, Nancy, as we think more and more about intraretinal fluid, somehow intraretinal fluid, is there a difference between intraretinal fluid and diabetic macular edema versus AMD in terms of the outcomes? It seems that we're used with VEGF inhibition to sort of tolerate a modest amount of intraretinal fluid in diabetics, and without seeing dramatic declines in vision. Maybe we have to look at it more carefully over a prolonged period of time. What are your thoughts about the relative negative impact of intraretinal fluid in diabetic macular edema versus wet AMD, AMD?
Well, I'm so glad you asked that, because diabetic macular edema is really a disease of intraretinal fluid. If you have subretinal fluid, it's really just overflow from the massive amounts of intraretinal fluid that you have. And maybe like others here on this Zoom call today, I used to think that some intraretinal fluid, in a diabetic may not be so bad. I treated as hard as I could, but if I couldn't get rid of it, I thought it was, tolerable. I have completely done a 180. I think intraretinal fluid is bad, and maybe they're not losing vision quickly like they would in an AMD patient. But this is where we lose the ability to improve vision in our diabetic patients. And we know that from all the crossover studies. We know that from Protocol U, where once we finally, get rid of the fluid, nobody's vision got any better. I really do think that we should be more aggressive getting rid of intraretinal fluid in diabetes, not because they're losing vision. It's because we're losing the ability to make their vision better.
Certainly, we've seen that, many of us that do use Ozurdex, when we eventually do put the Ozurdex implant in diabetics and the retina dries up, we're not seeing the vision gain that we expected. And wasn't clear what the mechanism is, but again, we postulated that it's because we waited too long and tolerated intraretinal fluid for too long. But it's an interesting concept that we're now focusing, but I agree with your point completely, Nancy, that diabetes is a disease of intraretinal fluid, and we've been, at the same time, tolerating it for a long period of time.
Maybe we should have some more urgency about it. So,
yeah.
Nancy, I think your study was, your analysis, the post hoc way of looking at some of these studies is important because of, well, one thing obviously is the categorization of intraretinal versus subretinal fluid, which I think clearly that's something that for the future we really should be considering in a greater and greater extent in all of our trials, including the randomized clinical trials going forward. But also, you are citing ETDRS visions rather than Snellen visions. And this is a group of patients in whom Snellen visual acuity testing is so variable. The conditions with which we test our patients, whether it's autorefractions or wall visions, the contrast and lighting around that makes the data acquisition very, very difficult and I think somewhat unreliable. So when we look at large real-world studies like IRIS or other huge population databases that are relying on Snellen vision, I think it's just harder to really know what to do with that data. So although it is a post hoc analysis that you presented, we are using very well-driven ETDRS protocols to get visual acuities, and I think it adds to the robustness of the point that you're making.
But thank you, Tarek, but I do want to say that I can cherry pick the studies that make my hypothesis. And I want to throw this back to Rishi, who actually in his talk presented a Hawk and Harrier analysis that said persistent early fluid actually does affect visual acuity. And I will say that, Rishi, in your study, you showed the separation of lines, but it was like 2 or 3 letters. Now we've made a big deal out of 2 or 3 letters before in our past. Cat trial comes to mind. But Rishi, your Hawk and Harrier analysis, and I think Jeff even commented on a view analysis that says early fluid does matter. Rishi, do you have any thoughts on this based on your work?
So I think all of these, fortunately or unfortunately, Nancy, are done in the setting of clinical trials, right? So you have very, very good mandated approaches. Clearly, visions are and monitoring is in part of that paradigm, right? But I think the point of showing even 2 or 3 letter differences, imagine what the difference might be in the real world in our patients. And the one example I could give you from the talk that I gave this morning was just the difference in the central subfield thickness variability. I mean, if you look at the studies, Ivan Cat and the V1 and V2 studies, they replicate the data, but with a very, very low impact on vision, maybe 5 letters, maybe 6 letters. So a line of difference, which isn't huge, right, if you think of that. But it's much bigger in the real world, and our study validated that. It looked at almost 10, 11 letters of vision, 2 lines of vision. And for the patient that's, in your office, that could be the difference between driving and not driving, the difference between, being without a caregiver and with a caregiver, recognizing faces. I mean, and all of these are, we talk about these as surrogates for visual function, but they really aren't, right? Visual acuity is so variable in this disease state. So I think of it in the way that, and this has been shown in some of the studies recently, that visual functional questionnaire and any IVF Q25 scales are very different in those with persistent and non-persistent fluid. So that's another validation that there is a larger impact here amongst that, even without, 2 or 3 letters of vision change. That might be just, the canary in the coal mine sort of thing. There's a larger picture at play at probably.
Nancy, I also think it's really important that you highlighted that in these studies, patients have been aggressively treated to get to that point. So it's not as if we're seeing a patient who has intraretinal fluid, we clear that up, there's subretinal fluid after 1 or 2 injections, and we say, that's fine, we can leave that. These are patients who are treated aggressively. You've tried to get them as dry as possible, and you're maintaining that. And I think we still have to learn about what this looks like in the real world, as we're not seeing such aggressive treatment and there's persistent fluid. How do we manage that?
Well, and, the first take-home point was, despite our best efforts, almost 45% of people could have one type of fluid or both. And I don't think anyone here has a clinic of where everybody's dry. So we're continually facing that persistent fluid question. And how do we handle it long term? Because at some point we have to put our patients on a maintenance program that maintains their visual acuity gains for the long term. As Lite showed, we're horrible at that. We have to realize this is a chronic disease, get people on a treat and extend maintenance program that maintains vision long term and keep them coming back to maintain their vision.
So the way I changed my management with this new information is that whereas previously I'd be very aggressive in trying to get rid of all the fluid, and even if I couldn't get rid of all the fluid, then I would be actually recommending fixed dosing, like monthly treatment for these patients. But with this new information, that gives me a little bit of flexibility in trying to extend the treatments, just looking at that small sliver of SRF if it's present. So, it gives me a little bit of variability approach or not, but, at least with the information that we have now, it is something possible.
Well, and you're right, Lite, we need more information. The fluid study was only a 2-year study, and you were showing data, for 10 years or more. So we don't have enough data.
Okay. It's wonderful to discuss this, because how much we discuss, we learn more, and we have more exciting with these new ideas, new trials, and so many good information. But we have to move on. And now we have Jeffrey Heyer, a very well-known scientist And we have Drew, that's going to be a wonderful talk. Jeffrey, introduce yourself.
Thank you, George, and thank you, Tarek, for inviting me to speak today. You know, with the advent of the anti-VEGF era, many of us thought that research endeavors would be stymied due to the outstanding effects of anti-VEGF agents and the management, certainly, of neovascular AMD. Fortunately, we're not stymied by those outcomes, and they've continued the work that hopefully will continue to advance our field, continue to treat patients with diseases such as neovascular AMD to a better effect. It's on behalf of the Tenaya and Lucerne investigators and their study teams that I have the privilege of presenting the phase 3 top-line results of faricimab in neovascular AMD. My financial disclosures are shown here, and I do serve as a scientific advisor to Genentech. It's also important to thank all of the investigators and their study teams and the over 1,300 participants at over 270 sites worldwide that compose the Tenaya and Lucerne studies. So faricimab is a bispecific antibody designed as a single molecule that attacks two targets. One arm hits Ang2, the other arm blocks VEGF-A, and it has a modified Fc portion that reduces systemic exposure and reduces inflammatory potential. Tenaya and Lucerne were randomized, double-masked, multi-center studies designed to evaluate 6 milligram faricimab in doses up to every 16 weeks versus 2 milligram aflibercept on label. Aflibercept patients got 3 monthly loading doses, and then they were treated every 8 weeks on label. Faricimab 6 milligrams got 4 initial loading doses. There were then 2 disease activity assessments at weeks 20 and 24 that were based on visual acuity, anatomic data, central subfield thickness measured by OCT, and investigators' evaluation. The first assessment was at week 20, which was 8 weeks following their last injection. And if patients demonstrated disease activity at that point, they were treated, and from that point on through week 60, received every 8-week injections. The second disease activity assessment was at week 24. And again, if patients demonstrated activity, they were treated then and then given every 12-week injections out to week 60. And finally, if they did disease activity at either of those 2 visits, they returned at week 28, now 16 weeks from their last injection. They were treated and then maintained on a Q16-week regimen. The primary endpoint was the change in best-corrected visual acuity from baseline, averaged over weeks 40, 44, and 48. And this is a 2-year study, and the second year will have a personal treatment interval based on various criteria. Patient eligibility is shown here. These were treatment-naive patients with subfoveal, juxtafoveal, or extrafoveal CNV with a subfoveal component measured by fluorescein or OCT, and visual acuity of 2032 to 2320. Patient disposition was excellent. In Tenaya, 671 patients were enrolled. 7.8% of patients discontinued treatment in the faricimab arm and 4.5% in the aflibercept arm. In Lucerne, 658 patients were enrolled, and 5.4% of the aflibercept patients discontinued treatment versus 6.7% of the aflibercept patients. So overall, patient disposition was excellent over the first year of study, and that's despite COVID. The COVID-19 certainly impacted to some extent. COVID-related missed visits were generally well balanced across treatment arms and had little impact on data quality. Supplemental and sensitivity analyses were performed, and all results were consistent with the primary analysis. Baseline patient demographics are shown here, and again, were well balanced across all treatment arms. Key baseline ocular characteristics are shown here, and again, these were well balanced across the different studies. Of note, patients in Tenaya had slightly better vision than patients in Lucerne, but again, these were balanced. Here again, baseline ocular characteristics were well balanced, and this included lesion location, lesion subtype, and total size of lesion. The proportion of faricimab patients in each arm is shown here, with roughly 45% of faricimab patients on a Q16-week regimen and almost 80% on a Q12-week or longer regimen. This was present in both Tenaya and Lucerne, and you can see the median number of injections in the first year in the faricimab patients was 6, and it was 8 in the aflibercept patients. In Tenaya and Lucerne, the primary endpoint was met, best-corrected visual acuity gains from baseline, with faricimab dosed up to every 16 weeks were non-inferior to aflibercept, as shown in this forest plot with tight confidence intervals. All arms demonstrated the rapid gains in vision typical of a strong anti-VEGF agent, and these gains were sustained in all arms, again, despite the fact that the majority of faricimab patients were on extended dosing regimens. Here we see percentage of patients with 3-line gain and percentage of patients avoiding moderate vision loss. And again, these were comparable across the arms and across the studies. Again, keeping in mind, this was despite the extended dosing regimen on the majority of faricimab patients. Here we see all arms again demonstrating rapid reduction in central subfield thickness, and this was present in the aflibercept and faricimab arms. And again, hitting on the same theme, this was despite the extended dosing regimen of almost 80% of the faricimab patients. There were low rates of adverse events seen with either treatment. Here we see the common ocular adverse events, and again, we look at these very carefully in all studies, but it's especially relevant with recent outcomes that we've seen in studies. These rates were relatively low. There was a numerical increase in the number of vitreous floaters in the aflibercept, in the faricimab arm relative to aflibercept, and there were numerically more retinal pigment epithelial tears in the faricimab arm as compared to aflibercept. Here we see the rates of intraocular inflammation, and these rates were low in both studies, but intraocular inflammation was numerically higher in faricimab versus aflibercept. On average, it was 2% in faricimab patients and 1.2% in the aflibercept patients. Of note, there were no cases of retinal vasculitis or occlusive retinitis in either study. There was one patient who had a retinal artery embolism. This was a patient who had a Hollenhorst plaque in the faricimab arm. Other important safety events are shown here, and these were balanced across the studies. In particular, we often look at APTC events, and we see that these were low in all of the treatment arms. So in summary, Tenaya and Lucerne met the primary endpoint, which was non-inferiority in mean change in best-corrected visual acuity, with faricimab dosed up to Q16 weeks as compared to aflibercept Q8 weeks on label. Durability was good, with almost 80% of patients on a Q12-week or greater regimen with sustained visual acuity and central subfield thickness. Faricimab was well tolerated, intraocular inflammation rates were low, and on average reported in 2% of faricimab patients and 1.2% of aflibercept patients. Tenaya and Lucerne are 2-year studies, so we will certainly look forward to the data that comes out next year for these studies, also as it relates to the personalized treatment interval. Again, I'd like to thank my co-investigators, their study times, and the patients for this work. Thank you.
For Q16, that's amazing. But one question that's coming in my mind is this 2% of inflammation that's show up during the trial. Do you need to treat this patient, and if need to treat, and how to treat? Just drops, or need to use oral steroids, something like this?
So the best data we have right now is that these were mild cases of inflammation that did not have impacts on vision, but that data is being studied very carefully and in depth, and we'll have more about those outcomes at a later meeting. It's important to note these were not the severe inflammatory events that have been seen with other agents and in other studies. But again, it's critical to study that in depth and have more data on that.
Okay, thank you. Barry?
Jeff, again, a great talk as always. And this compound, this bispecific molecule, is very exciting to us. I think we're all eager to see what it can do if and when it's eventually approved. What's impressive is the high percentage of eyes that were able to be extended out there, were able to tolerate the Q16-week dosing. What was the amount of fluid tolerance in that? Can you remind us of the criteria for that extension when you look at the ones that went from 8 to 12 to 16 at those evaluations? Again, back to the conversations we've been having all morning with Nancy and intraretinal fluid and subretinal fluid. What was being tolerated there?
Yeah, so great question, Barry. And as you know, it's determining those tolerances in study designs that are really important to understand this. So the disease activity was the following: if they could have an increase, it had to be an increase of 50 microns or more averaged over the past 2 visits, or an increase of 70 microns from either of the past 2 visits, or could be a change of 5 letters or greater, a loss of 5 letters or greater averaged over the past 2 visits, or a change of greater than 10 letters over either of the past 2 visits, or submacular hemorrhage, or at any point investigator discretion that these patients needed to be treated more frequently. But once you entered a regimen, you maintain that regimen for the first year. So there weren't ongoing disease activity assessments.
So that percentage that was whatever that was, 48% or so that were on the 16-week, that was a fixed regimen regardless of what their fluid status was throughout the rest of that year. Vision was what it was as an outcome, and I'm sure OCTs are being done, but that analysis will be done separately in terms of ability to differentiate intraretinal and subretinal fluid. Those analyses will all eventually be done and available.
Correct.
It's very interesting. Again, I think this is again, it's going to be interesting how as we shift the goalposts continuously further and further out with these new molecular approaches. Exciting. Again, the Ang2 pathway being being part of this, much like the aflibercept had the PLGF as that added on to the VEGF alone. So we're seeing these combination products that are very exciting.
Well, what's also exciting, Barry, and I think it's technically not a combination product.
Right. It's a bispecific molecule, but 2 pathways. Right. It's not
the important point of that is if you have a combination approach, you've got to have superiority studies, and it's harder to get approval, and durability is not an approval endpoint. So in this case, where we have essentially one molecule, we don't need superiority to be able to benefit from the durability and anatomic benefits that we're seeing in the study.
Your point's very well taken. Again, I was inarticulate in that because similarly, aflibercept is not two compounds, it's one molecule that has impact on the PLGF pathway as well as the VEGF pathway. These bispecific types of compounds, single compounds, do have the advantage of, as a single product, they don't have to show superiority in the regulatory pathway, just non-inferiority is enough for them to advance.
Right.
Yeah, Jeff, is there any sort of finding you saw from the year one data, other than the durability effect that increased, that shows you that there's an Ang2 effect? Was there something in particular that you saw, other than the durability, that, that could come down to protocol, right? I mean, you could design a protocol to show durability, but what else did you see there that would be indicative to somebody to say, this is potentially an Ang2 effect?
So that's a great question, Rishi, and one that is being considered. So there are a couple benefits you saw. Durability was one, and there's preclinical data that suggests the combination of Ang2 and anti-VEGF gives you greater durability. There were some anatomic benefits as well. When you look at time points that are the same, say at 12 weeks, at 16 weeks, where they'll still have had the same number of treatments up to that point, there were benefits shown there. Probably the strongest argument against that being solely anti-VEGF are studies like Harbor and other treatments of READ3 that have looked at higher concentration anti-VEGF therapy without seeing actual benefits. But there's no way from what we've seen here to actually differentiate whether this could be still an anti-VEGF is higher. And so whether it's just a benefit from the combination or not is hard to differentiate just from this. And while I think it's important to differentiate it, I'm not sure it's important clinically, because if we're getting these benefits, the benefits are what's important and not necessarily the cause. But it certainly would be nice to understand that, because you might extrapolate from that as to how you treat other diseases.
Derek?
Well, I think, it's just so wonderful and exciting to see what's coming up. Jeff, do you think that as we move towards these longer duration agents, that the way in which we all treat our patients will deviate any from treat and extend, or are we going to be applying our same thoughts of treat and extend when you have an agent that works for 3 or 4 months? Do you think we'll stretch it out to 4 months and then getting more into a fixed interval type concept, because we are reducing the treatment burden so long and we want to, say, minimize the variability of central macular thickness? So how do you, obviously we don't know, but what do you think?
Well, the good news is we've never been fully dependent on data. And so we'll adapt this to what we think is best. I think there's no question that those of us who are treatment extenders, and we know from the PAT survey and other surveys that that's certainly the large majority of us, will, I think, naturally look to extend these. So, for instance, when I have one-eyed patients, I will, in general, never extend beyond 8 to 12 weeks, just because I'm afraid that we don't have much drug on board after that. But if I have an agent that has clinical trial data that says it looks effective at 16 weeks, I'd be more inclined to do that. I think one of the other major factors in this is going to be exactly the study that Nancy and I are involved in, is the home OCT, because that will certainly give you more confidence. If that study demonstrates that we're able to pick up subtle changes in fluid recurrence, that could also help to offset some of our concerns as to any extension beyond what we're normally comfortable with.
That's really So super exciting to think that we can bring in these other factors into our treatment decision paradigm like home OCT. As a brief concept of home OCT, do we know if the manufacturers, which we know there are more than one, are approaching this in a manner that will make it affordable for the hundreds of thousands of patients in the U.S. and millions across the world to employ such technologies, in managing their disease?
So I think the overall design, at least of one of those developers, is to be able to design a device that is able to be put in a home and is affordable. And again, what the reimbursement paradigm is for that is certainly beyond my pay grade and my expertise. But I think the hope is that these will not be the $100,000 to $150,000 clinic OCTs, but something that is readily affordable and able to be mass produced and put in homes with a level of resolution that works for detecting disease. Nancy, do you want to comment any more on that?
Also above my pay grade too. But that is the hope, because you have to make technology affordable in order for it to be used. We just can't be excited about great technology. It has to be relevant and it has to be deployable. But we're still in the early stages. And the study that Jeff and I are on is really about feasibility. Is it even possible to drop ship to someone's home an OCT machine and have them use it, and then have the data get to the cloud, and then have an AI read it, or have a physician monitor it? So, I think that we need to take those steps first, and it's all exciting. And then I think other people are going to figure out how to make it relevant and deployable.
Well, certainly, again, as you pointed out, both of you, there are several companies involved, and they're acutely aware of this issue. They're focused on they know that this is not a viable technology if it's not affordable. So that's their combined. It has to be clinically meaningful in that what it measures, and it has to be affordable. Without that, the model fails.
Agreed.
I have a question from the audience. Mario Ventresca from Canada. He asked if you have any data from faricimab to works in PED or kind of complex CNV like polypoidal. Do you have any good data that show that's different or have better result in this kind of specific situation?
So excellent question. And this was just the top line data that actually has come out remarkably quickly, as we really just started getting the data lock at the end of the year and the beginning of this year. Those analyses will be forthcoming.
Good. I think we are approaching for the end of the webinar. That was wonderful. I have to thank all of you, because we are almost 2 hours talking, but what's so exciting, that's almost, I have no notes, that was so fast. But anyway, I think we are turning to Tarek to have some words.
Well, thank you, George. And really, I just want to say thank you. And I can't imagine a better, more interesting, more comprehensive discussion of current and future management of neovascular AMD than we've seen here with all of you. And I really do appreciate taking the time to spend part of your Sunday with us and with really the rest of the world, or what is a very large audience of folks tuning in to see this. And you guys really have presented some very, very top line and highest quality talks. So I thank you all for your time, your contributions to the Retina World Congress, and this continuing education event, which I'll encourage you to certainly apply for your credits. And we look forward to your continued participation in such educational endeavors going forward. So again, thank you really from the bottom of our hearts for really fantastic discussion and talks. So thank you.
Just I wanted to add to Jeff and Nancy that probably the technology, whenever it's ready, and maybe India can do something for making it affordable. There's a lot of companies that are working on AI, and the government of India also is supporting engineering technology. They conduct a lot of hackathons. I hope one day we can make it available to the whole world.
That would be great.
Thank you, Tarak, and thanks for.
I have to thank all of the audience across the globe, and I have to remind that we're going to have the next edition of CME Credit going to be on May 23rd, going to be Sunday again. And I'd like to thank all the speakers and all the wonderful talks. We learned a lot. We're very exciting, very new data that's going to help a lot the patients across the globe. And I have to say, for the audience, sometimes I get some question that's not in this scientific topic. I can't ask this because CME Credit, we can go out of this specific topic to broad discussion. But I appreciate a lot all the questions that's come and you stimulate to continue asking. Thank you very much. All of you was great. I believe that's gonna meet again on May 23rd. Thank you. Have a wonderful Sunday. Bye.
Thank you all.
George. Thanks,
Bye.
Bye, everybody.
Bye.